I hope what I'm about to present today is a little thought-provoking. The majority of my talk is not where our clinical practice is right now, but my hope, and I hope yours as well, is that some of the topics that we'll present for this next hour will hopefully one day be part of our practice as a way of best individualizing treatment options for patients who struggle with mood disorders. So I was asked to talk about biomarkers, what they are, and what their potential relevance could be to the practice of bipolar disorder. So, why are biomarkers relevant to think about as enhancing or evolving your practice? Well, we've heard a lot already from Professor Gami about the impact of depression and the historical trajectory that mood disorders, unipolar, bipolar, manic depressive have had. This is pretty compelling data I think all of us can relate to. The World Health Organization, with a very important study funded by the World Bank, looked at disability-adjusted life years, or DALYs. Projections by calendar year 2020 is that depression will have the second highest rank of premature morbidity or mortality, just behind cardiovascular disease. That as a globe, we will have 850,000 suicides annually, with a prevalence rate of depression more than 120 million people. So how could biomarkers help us? What I want to do is talk about three things. I want to define a biomarker for you. I want to show examples of what a biomarker is that should already be in your clinical practice. And then I want to talk about biomarkers in the context of bipolar disorder. Could a biomarker help us with a diagnosis? Excuse me. Could a biomarker help with a treatment selection, or what we might call a pharmacogenomic probe? So biomarker definition is listed here, and this is taken from one of our Canadian colleagues, Benicio Frye. Not a brother, wrong spelling, younger, better looking. But this is the biomarker piece that came from the International Society for Bipolar Disorder, and it really gives a very good definition of what a biomarker is. We want a biomarker to quantify a biological process. We want the biomarker to be valid, reproducible, acceptable to patients, easy to interpret. So you're going to hear a lot of my opinions today. A biomarker that requires an arterial line, a lumbar puncture, spending 4 hours in a brain scan, that strikes me as a biomarker that's going to have real trouble becoming friendly for a community sample. That's a hard biomarker. In contrast, a saliva sample may prove to be far more patient-friendly. The development steps, I'm not going to go over in any great detail today, but there's a process as how we identify a biomarker, we validate what it's telling us, and we look then at diagnostic or prognostic outcome measures related to testing that biomarker. Again, from Benicio Frye's work, when we look at biomarkers, there are many. And I think this is something we need to remind ourselves. A biomarker is just not a piece of DNA. Yes, we can have genetics, as you see in the lower part of this slide, a gene or a variation in a gene that confers risk to a disease or to a particular treatment response. But we need to remind ourselves that biomarkers or biological markers can be brain imaging data points. Some examples that you see here is biomarkers in bipolar disorder. They can be measurements that we can draw from the blood that give us an idea of protein levels or metabolites or function. So the biology is widespread. It goes far beyond genes, but we really recognize the importance of validation and testing that biomarker. So, are there examples of biomarkers that really should be in your practice already? And the answer is yes. Here's one of them. A number of years ago, a very small but critical study, I apologize, the reference is not there. It is in, I can get that to you. But this identified in a very small group of Han Chinese patients a genetic variation associated with developing Stevens-Johnson syndrome, which, as you know, is a life-threatening rash that we can see when we use carbamazepine, Lamotrigine, a number of other anticonvulsants. This genetic variation, which is the HLA-B1502 that you see referenced, was identified in every single patient that developed Stevens-Johnson syndrome in this small study in a Han Chinese patient group. So one of the things that we knew we wanted to take a look at is this struggle of the diagnosis of bipolar disorder in non-adults. You know that this continues to be a challenge, and one of the ideas that we had is, could a biomarker help facilitate the right diagnosis for these young people who are having significant psychiatric symptoms? We saw an opportunity to collaborate with a study that is abbreviated TEAM, which stands for Treat Early Adolescent Mania. What I'm showing you here is some of the methodology of our work. I apologize for the delay, but I felt as if the talk had too many method slides, and I wanted to really hit the high points with you this morning. We said, let's look at the genes that have been well established, reported in the literature as conferring risk for bipolar disorder. And you see those here. To your left, you see the name of the gene. The next column, the SNP, is the piece of genetic variation that is coded. It references what that specifically is, the minor allele frequencies, et cetera. We took those three genes, ODZ4, ANC3, CACNA-A1C, and we said we're going to look at those very carefully. We're going to look at those disease risk genes, and we're going to ask if they are overrepresented or more robust in bipolar patients where we know their illness started as a non-adult. So we have three groups of data here. The first one is the TEAM study. This was a study of Barbara Geller's that had as its primary goal to look at treating adolescent mania with either risperidone, divaproxodium, or lithium. But in that clinical trial, there was a blood sample that was saved for genomic analyses that is part of this analysis, and it's referred to as the TEAM study. So what I want you to remember from this is a group of manic young people, average age, I believe, around 12. So we don't need to clarify if it was early onset illness. It is by virtue of the trial that they're in. The second bullet is from Mayo. That's our Mayo Clinic Bipolar Biobank, and we have 732 people in this analysis where we had detailed clinical review and structured diagnostic interviewing confirming who had what we call early onset cases, that EOC with a sample size of 261. The majority are otherwise known as late. The other 776 controls that you see in that third bullet are coming from our Mayo Clinic Community Biobank. We have lots of disease biobanks. We're talking about the Bipolar Biobank. The Community Biobank is where we actually get our healthy controls. So I'm going to focus on the last bullet here just for time reasons. So again, we wanted to look at these genes of disease risk that are already established in the literature and just ask, Are they more robust? Do we see more evidence of those genes in our early onset cases than our late onset cases? That last bullet is really referencing our analysis, which we refer to as a genetic risk score. Simple count, odds weighted. It just means we're looking at those specific genetic variations from those 3 genes and saying, do our early onset cases have more of those than our late onset cases? And we rerun that analysis weighted on the strength of the data from those first studies that I presented to you. Small sample size. But what the data is suggesting, currently in press in the Journal of Clinical Psychiatry by my colleague Paul Crow-Arkin, is that we do seem to get a suggestion that some of these genes that are established in the literature as conferring risk to bipolar disorder are more prevalent in our early onset cases. This is not ready for clinical prime time. I'm not going to ask you to start running genetic tests on a 14-year-old where you're not sure they're depressed or bipolar, but I want to highlight to you some of the newest research currently in press. It's really thinking about ways to try to answer that question. If we can have a blood test that helps a clinician clarify bipolar disorder, yes or no, unipolar disorder, yes or no, neither of the above, that's an advance in our practice. And I want to emphasize time and time again that technology or these types of really exciting areas of research do not replace a comprehensive, competent clinical evaluation. So that's one example of a biomarker that could help make a diagnosis. And we were focusing on genetic variation or how our DNA might be different. I wanted to give you a second example that's not about DNA, but a potential biomarker that's a protein that we can measure in our blood. This was a study that we did a number of years ago that got published in 2015 with now a validation study going forward. We were interested in trying to evaluate whether a rapid assessment of 300 proteins could distinguish mood disorder patients from healthy controls, and secondarily, bipolar and unipolar patients from each other. So that first bullet is our methods. We looked at more or less about 300 patients recruited into our study at the Mayo Clinic Depression Center. We were utilizing technology that was established by rules-based medicine, Myriad Genetics, and in essence, they have a platform that can rapidly measure 320 proteins. This was an investigator-initiated study by myself, funded through Myriad. The proteins that got on their platform were developed through the years in collaboration with different types of clinical trials that were focused on inflammatory mediators, immune mediators. We saw this as an opportunity, really given that our work in mood disorders has very recently focused on these inflammatory markers, these inflammatory mediators. We saw this as something we wanted to look at in an exploratory fashion. Suffice to say, small sample size, we were robustly conservative with the amount of Bonferroni correction that we were doing, looking at covariates, et cetera. Here's the data that was published last year in Translational Psychiatry. You can see that we have 4 groups. The primary analysis was looking at all mood disorder groups, so the red, yellow, and blue versus controls. But I'm showing you the data by each of the 4 separate groups. What you're looking at are 6 proteins: growth differentiating factor 15, hepsin, hemopexin, matrix metalloprotease 7, retinol binding globulin 4, and transthyretin. How many of you have even heard of one of those before? So for me, I've been in this business for a while. We've been studying transthyretin for a long time. This is a carrier protein that takes thyroid hormone from the periphery into the brain. So I was kind of pleased to see that there. And I was very struck to know that retinol binding globulin 4 and TTR are highly co-localized. But I think this is a good example of what Professor Gami was referencing this morning. We don't know what we don't know, and looking into new avenues and arenas may prove to be quite useful in having a better understanding of what our mood disorder world looks like. So we've got these proteins. Many of them are mediating inflammation. Many of them are protein kinase linked in some way, and we can show you that we have differences in mood disorder patients versus controls in that regard. What I want you to focus on is the red bar, which are the bipolar 1 depressed individuals, are driving most of this difference, that they in fact have the greatest separation from our controls, and our BP2 depressed in yellow and our UP and depressed in blue seem to be intermediate. Now I'm showing you the data in a different way with this table, and I want to have you start from the left part of the slide and go right. So there are those 6 proteins that are on statistical analysis significantly different from each other. The next column is looking at mood, BP1, 2, UP versus control. The yellow boxes are where we have statistical significance. The pink boxes are a receiver operating analysis where we look at response prediction. Pink is good, or purple's good, pink is fair. What I want you to focus on are the yellow boxes. When we look at bipolar 1, 2 UP versus controls, we see one of those signals is there. When we look at BP1, BP2 versus controls, we get 3 of them. And when we look at BP1 versus controls, we get all 5 of them back. So the data would suggest that these 6 proteins, which are different from healthy controls, really would suggest that the BP1s are driving that. And we don't know why that is. Why would these 6 proteins in bipolar depression separate from patients who don't have a mood disorder or patients who have BP2 or UP? Is it something about the depression that biologically is different? Clinically, you know that many bipolars, when depressed, will have atypical symptoms of depression, hypersomnia, hyperphagia. They don't have that melancholic angst that wakes unipolars up at 4 in the morning. Could that be this difference? Could be. Could it be that these 6 proteins in depression have absolutely nothing to do with depression? And perhaps it's a residue of past manic episodes. Could be. We don't know. But we were very intrigued by this exploratory data and are now going forward with validation studies. So again, example of, could we have a day in the future where a protein marker helps us delineate unipolar from bipolar disease? This is not clinical prime time right now, but I think as clinicians you will agree, in addition to our comprehensive, competent clinical evaluation, if there's tools that help us delineate diagnosis or treatment, that's got to be an advance in our practice. And invariably, we go to antidepressants. How many of you have a bipolar, how many of you in your practice treat patients with bipolar disorder and regularly or somewhat regularly prescribe antidepressants? Okay, I would argue that you are probably outstanding clinicians. We have few treatments for the depressive phase of bipolar disorder. Patients live in depression far longer than they live in mania or in euthymia, whatever that might mean. And I think as clinicians, we're obliged to try to reduce symptoms, and we invariably go to antidepressant medicines. The literature on whether medicines such as antidepressants are effective is quite controversial. But we're not going to not treat someone who's coming into our office. So I as well prescribe these medicines with variable response. But this slide is really to underscore how common it is to use antidepressants when treating the depressive phase of bipolar disorder. Here's what we worry about, and Professor Game had referenced some of this in his talk. Infrequently, this is not common, but we can see patients start antidepressant therapy and become manic. How many of you have had that happen in your practice? So this is not a good outcome. Sometimes this can be a disastrous outcome. So when I think about biomarkers, and I think about the depressive phase of bipolar disorder with how little evidence base we have, and that we invariably go to off-label treatments, this is another area, in my opinion, that if a biomarker can help guide us as to safe waters, that changes our practice. So that's something that we were interested in looking at with regards to, could a biomarker help us identify someone who might have an antidepressant-induced manic episode? What I think is important is to understand the literature before you focus on one biomarker. So for us, we did that a number of years ago. We looked at the clinical literature of correlates that were associated with antidepressant-induced mania. You see them here. When I am cogitating on whether or not an antidepressant is going to be used, I think of this list, and I literally count how many of these bullets a patient in my office might have. And if someone has had antidepressant-induced mania with every other antidepressant they've had in the past, we're not going down that road. So you can see these risk factors that are there. I will underscore the hyperthymic piece that Dr. Game referenced. I think in my clinical practice, this is very common. Hyperthymic patients who get depressed, I really worry about working with unimodal antidepressants by themselves. And I will confess that I am very Ekeskielian in my approach in that regard. So here's a study that we did a number of years ago that I think is really relevant for this concept of looking at risk factors. We had a study through the Stanley Foundation Bipolar Network where we randomized bipolar patients to bupropion, venlafaxine, or sertraline. Different mechanism of action antidepressants. We were wanting to look at whether or not there was differential efficacy or differential risk of mania induction. The data I'm presenting to you now has nothing to do with the outcome of the antidepressant. It's looking at the baseline symptoms before the antidepressant got started. So what you see is we have three groups. The group in light blue was a group of bipolars on a mood stabilizer, depressed, got randomized to one of these antidepressants, and they did very well. What you're looking at with these three bars is the baseline Young Mania Rating Scale score. These patients are syndromally depressed, but as you know, we always track the presence of manic symptoms. So what you see is the group that went on to do really well with the antidepressant in blue had a Young Mania score of 2. Now let's put that in perspective. A Young Mania score of 20 gets you into a clinical trial for mania. A Young Mania score of 11 or 12 we generally think of as hypomania. A Young Mania score of 2 should be nothing, right? Maybe too much coffee one day. But I will have you compare that blue bar to the red bar. That red bar are patients who have a Young Mania Rating Scale score of 4, but they are in fact the ones who go on to have a manic episode when that antidepressant was prescribed. And it gets exactly to Dr. Game's comment about looking for mixed symptoms in depression. And here's a piece of evidence to suggest it is unsafe to pursue antidepressant treatment. And if you recall from Dr. Game's lecture, he was really highlighting the concept of motor and energy, and that was the driving factor in exploratory analysis. So when I see a depressed patient in my office, depressed, anhedonic, highly self-critical, suicidal, binging on carbohydrates, agitated, pressured, pushed in the office, that is not someone who's going to get an antidepressant by me for this type of literature. And I think this concept of 3 symptoms in depression, which we are showing here, very compatible with DSM-5, is a relevant clinical profile for you to look for in your practice. So let's move beyond the clinical piece and see if there is a genetic piece that might be relevant. So one of the studies we have in our bipolar biobank is looking at the genetics of antidepressant-induced mania. The model that we're looking at is that middle graph, starting an antidepressant and quickly becoming manic. The serotonin transporter has been a genetic variation of great interest. There's a number of variations that we can see with the serotonin transporter. What we're talking about specifically is the LS allele. Recall that the L allele, or the long form, is the gene that produces the protein that's called the serotonin transporter. That sits on a neuron. L means long, which means lots of serotonin transporter is on the neuron for a molecule of serotonin to sit in, or in fact a molecule of fluoxetine. The S allele means the short form, and it means that there is significantly fewer transporters that are produced for a molecule of serotonin or a molecule of an antidepressant to sit in. Data would suggest that the L form, the long form, the LL genotype in unipolar depression is associated with a better antidepressant response. The data would suggest that the short form, the SS genotype, is associated with a reduced response and a higher side effect burden. And it was the higher side effect burden in those studies that got us thinking that maybe the S form has some liability for antidepressant-induced mania. With each hospitalization for mania, we see a decrement in NAA. This got us thinking, could NAA help us stage disease? Can it help us count episodes? Another Canadian researcher, Dr. Hajek and colleagues, has shown very nicely that when lithium is used in the long-term management of bipolar disorder, and what I'm having you focus on here is the gray regression line that's pretty flat, we don't see that age-associated reduction in NAA. That lithium may, in fact, be attenuating that NAA marker decrease, hopefully for therapeutic intent, although I would argue that that's not yet shown. So the lithium story with NAA got us very interested in Lamotrigine. What I'm showing you here is the evidence base that while not regulatory approved for the acute phase of depression, we actually see Lamotrigine can be helpful when we look at all the studies put together. From an anticonvulsant standpoint, mechanistically, we think Lamotrigine, by blocking sodium ions, is blocking the extracellular release of glutamate and the extracellular release of aspartate. And it is proposed that the anticonvulsant effect of Lamotrigine is its anti-glutamatergic mechanism of action. We just were talking about NAA. I'm going to look to this part of the audience here to show this. We were keen not to think about glutamate, but recognizing that through the sodium channel blockade, we're blocking the release of aspartate. So if this ASP is not getting released into the synapse, and we are building or increasing the intraneuronal store of aspartate, and if we've got acetyl-CoA hanging around, we're going to produce more N-acetyl aspartate, or NAA. That was the hypothesis of this study. I think for time, I'm just going to go right here, of Dr. Paul Crow-Arkins that was published last year. In a small study at Mayo Clinic, bipolar depressed patients in blue had a significantly reduced NAA signal in comparison to age-matched controls in red. Those patients then received 12 weeks of Lamotrigine, and you see that that blue bar has now increased significantly to look just like healthy controls. So it's another imaging study where we can see NAA deficits in bipolar disorder, and those deficits normalize with lithium, and in this small study with Lamotrigine. So what I want to say in closing from a biomarker standpoint is biomarkers are positioned to help us facilitate the right diagnosis to the right patient and the right treatment to the right patient at the right time. The second half of this talk is all research, but I hope you can see, I hope you share how interesting it is, but I really hope you see that this type of research has the potential to impact our clinical practice with further prospective, larger studies. The third bullet, there is evidence already in your clinical practice that genomic medicine is changing the way you should be thinking about medications. It is very small. It's, in essence, carbamazepine, citalopram. There's a couple other examples as well, but that concept is going to grow, and it is going to grow rapidly. The more we understand what a biomarker can be, the more we design technologies that really bring those clinical decision support tools quickly to our office, we have the potential to transform our practice. Thank you very much.